Now we would see that actually there are two parts of femur, the head and the neck, and the trochanter and the shaft, lesser trochanter and the shaft. So you have to understand two types of sections. One is this section. So these are the muscles that are moving, that are parallel to the neck. And the second is this section, in which the muscles are parallel to the thigh. Now you have to understand that the hip is a ball and socket joint. This is the ball and this is the socket. So in a ball and socket joint, you have an axis which passes through the center of the ball, and any muscle which is inferior to this axis. So this is one axis which is passing from anterior to posterior. So the ball can have a AP axis, can have a side to side axis like this, side to side axis, or can have a supero-inferior axis, Now we'll concentrate on the antero-posterior axis, which is this. So any muscle which is passing above this axis will abduct, and any muscle passing below this axis here, will adduct. So any muscle passing anterior to this axis, anterior to this anterior to this axis, supero-inferior axis. Any muscle is passing anterior to it, it will internally rotate, like Psoas major. It will internally rotate. And any muscle passing posterior to this axis will externally rotate. For example, if you are looking at it from top, and this is the supero-inferior axis, and supposing this is the anterior side, this is the posterior side, and this is the trochanter, any muscle passing anterior to this axis will internally rotate, and any muscle passing posterior to it will externally rotate. Now it's important that the Psoas is passing anterior to this axis, anterior to the rotational axis. Therefore, it internally rotates when the head, neck and trochanter are joined. But if there is a fracture neck or femur, then this Psoas will start externally rotating, because then this rotational axis will move to the axis of the femur. Okay, so when there is a fracture, then the axis of rotation moves to the trochanter, the shaft of femur, and therefore the Psoas, which was initially an internal rotator on this axis, becomes an external rotator on this axis. So these are the muscles that are trying to move the hip: adductor, abductor, internal, external rotator, and flexor-extensor. On this axis, there can be a flexion or there can be an extension. This axis. Okay. So after understanding these axes, let us try to see the neck. Okay. Get a section of the neck and see that this is the superior border of the neck, this is the inferior border of the neck, and you have an anterior surface and you have a posterior surface. All right. Then we have the arteries. On the posterior surface you have the lateral epiphyseal vessels coming from the side on the anterior surface and the posterior surface. So these are the arteries which are coming. Then we will have the synovial membrane. So the synovial membrane comes like this, goes around these vessels forming the retinacular vessels, goes like this. So this is the internal layer of the synovium, and outside it we will have the external layer of the synovium, and in between the two we will have the fluid. If the fluid increases, because outside the synovium is the capsule, you have the capsule. Now this capsule is thickened by the Y-shaped ligament of iliofemoral ligament of Bigelow and the pubofemoral ligament and the ischiofemoral ligament. So this capsule is thickened, and when there is a increase in fluid in the hip joint, then this because of this capsule all around it, it can lead to tamponade, that means high pressure and pressure on the blood vessels. So this is the capsule that you see. Now under this capsule you will have the muscles which are around the hip, and these muscles which are around the hip can be obturator externus arising from the obturator foramen, going round the neck of femur and getting inserted into the trochanter. So this is obturator externus. Anteriorly you will have the iliacus, the psoas, the pectineus, iliacus, the psoas, the pectineus, and above that you will have the sartorius. On the abductor side you will have, on the outer side, the tensor fascial arta, and on the inner side you will have the gluteus maximus. These will be the abductors, and this obturator externus is an adductor, but anteriorly this obturator internus has got the pectineus. This is the pectineus muscle, and posteriorly it has got the quadratus femoris. So the upper part of the adductors are pectineus, obturator externus, quadratus femoris, and the lower part are adductor longus, adductor brevis, and adductor magnus. Now the muscles that are behind after this obturator externus, you have muscles which are parallel to quadratus femoris. Above the quadratus femoris you have the inferior gemellus, then you have the tendon of the obturator internus, then you have the superior gemellus which forms the triflagellate tendon, and finally you have the piriformis. and this of course is the gluteus medius. So gluteus medius, piriformis, superior gemellus, obturator internus, inferior gemellus. These three forming the triflagellate tendon. And of course, covering all these muscles here, you have the gluteus maximus, and here you have under the sartorius. This is sartorius, this is iliacus, this is psoas, and this is pectineus. So under the gluteus maximus you have these muscles, and gluteus medius is covered by tensor fascia lata, right? Tensor fascia lata and gluteus medius. Then we have these muscles on the anterior side and these muscles on the posterior side, and the adductors, the superior layer formed by the pectineus, the obturator internus, and the quadratus femoris, and the inferior being formed by adductor longus, adductor brevis, and adductor magnus, and of course this is aided by gracilis. So these are the muscles that we talked about in the last YouTube, and that's why these muscles can be adductors, abductors, flexors, and extensors. Adductors are 3 superior and 3 inferior. The superior are obturator externus, sandwiched between pectineus in front and quadratus femoris behind. Then the 3 inferior adductors are adductor longus, adductor brevis, adductor magnus. The abductors are gluteus medius and tensor fascia lata. The flexors are from lateral to medial, sartorius, iliacus, psoas, pectineus. So these are the flexors, and extensors are from above. Below the extensors are piriformis. One flexor is gluteus minimus. So the extensors are piriformis, superior gemellus, obturator internus, inferior gemellus, quadratus femoris, covered by gluteus maximus, and internal to them of course you have this obturator externus. So these are the muscles which are in a section around the neck, this section. Okay, then we move on to muscles, or this section of muscles around the thigh. Let's see these muscles. We told you that the femur is a inverted triangle bone. Behind it you have the linea aspera, which has got a medial lip and a lateral lip. So this is the linea aspera, and this of course is the marrow or the femur. Now the most important thing that you have to understand is that the lateral lip gives a fascia, which is called as the lateral intermuscular septum, and the medial lip gives the medial intermuscular septum. But this medial intermuscular septum actually divides into two. This houses the anterior compartment. So there is a deep fascia which goes around like this. This is the extensors of the knee. These are the flexors of the knee, and these are the adductors of the knee, adductors of the hip. So this is the medial intermuscular septum, this is the lateral intermuscular septum, and this is the septum which is dividing the adductor and the extensor compartment. So, which are the adductors? The adductor is adductor magnus, like this, then adductor brevis and adductor longus. Adductor magnus, brevis and longus. And covering these muscles is the final adductor, which is the gracilis. These are the inferior adductors of the hip. Then you have the vastus medialis, vastus intermedius and vastus lateralis, and covering this is rectus femoris. Then from the lateral lip you have the biceps short head, and the biceps long head is not attached to the femur. So these are the biceps, two heads of the biceps, and on the lat. So this is on the medial side you have not the biceps, you have the two muscles, the semi-membranosus, which is the inner one, and semi-tendinosus, which is the outer one, and on the outer lip you have the biceps short head, which is attached to the linea aspera, and of course the biceps long head, which is not attached to the linea aspera. Now you have to understand that you have a membrane. This membrane is the membrane which is going from the adductors to the vastus medialis. This is the vastus medialis, this is the vastus intermedius, this is the vastus lateralis, and at this junction you have a membrane which connects the vastus medialis to the gracilis, that is the adductors. This membrane is called as vaso-adductor membrane, and this covers a canal which is called as the adductor canal. This canal is called as the adductor canal or the hunter's canal. And in this lies the femoral artery, vein, and nerve. And this hunter's canal is covered by a muscle which is called as sartorius. This canal is also called as the subsartorial canal. So this is the sartorius. This is also called as the subsartorial canal. Right. So this is the section of the thigh near about its middle. Now let us see what happens to the thigh as you approach towards the knee. So if you look at the femur from the back, this is the trochanter, this is the lesser trochanter, and here you are looking at the femur from the back. This is the medial condyle, this is the lateral condyle. You see that there is a medial spiral line and there is a lateral spiral line, and these have gone as the linea aspera, and then they have become the lateral and the medial supracondylar ridge. This is the medial side, this is the lateral side. So I told you that this will articulate with the tibia here, and this will articulate with the fibula. Here it will articulate with the hip, and of course here will be the iliac tuberosity, and this muscle would primarily be the gluteus medius, and from here will be the tensor fasciae lata, which will be coming down like this, forming the iliotibial band, and it will get inserted into the head of the fibula. Now this will also keep giving the lateral intermuscular septum, the iliotibial band, which will get inserted into the linea aspera, lateral lip of the linea aspera. Anterior to this linear lip, anterior to this intermuscular septum, is of course the insertion of the vastus lateralis. So supposing this is the intermuscular septum, here you will have the vastus anterior to this. This will be the vastus lateralis, intermedius, and vastus medialis. And vastus medialis will come and get inserted on this side. And of course, this will be anterior to the medial intermuscular septum. This will be anterior to the medial intermuscular septum. So the anterior, lateral and medial side of the femur right up to linea aspera is occupied by the vastus, the gracilis, the sartorius, and the rectus femoris in front. Now behind we told you that there is semimembranosus, semitendinosus, but on the medial side the semimembranosus and semitendinosus are muscles, one covering the other. The semimembranosus and semitendinosus not attached to the linea aspera, but the biceps arises from the lateral lip of linea aspera, and of course there is a portion of the biceps that is coming from the ischial tuberosity, and thus it has got two heads, one attached to the linea aspera and the other coming from the ischial tuberosity. So semimembranosus, semitendinosus on this side going to the anteromedial surface of the tibia, and the biceps on this side going to the head of the fibula, form the superior medial and superior lateral boundary of the popliteal fossa. The gastrocnemius muscle arising from the supracondylar ridge on the medial side and the lateral head from the lateral side. These two form the popliteal fossa. Inferomedial and inferolateral boundary of the popliteal fossa. So, popliteal fossa is semimembranosus, semitendinosus on this side, biceps on this side, and the two heads of the gastrocnemius on the lower side. So this is what the popliteal fossa is. Then finally you have a muscle on the femur which goes and gets attached to the posterior surface of tibia, and with tibia stationary it tends to externally rotate the femur on the tibia. This muscle is called as popliteus. Now we will study the anterior surface and how the vastae are attached to the patella and through the patella into the ligamentum patelli. So here is our head, neck, and this is the femur. And here you have the tibia, and here you have the tibial tuberosity and the anterior border of the tibia. So this is your intertrochanteric crest leading to the medial spiral line and the linea aspera behind. This is the subtrochanteric crest leading to the lateral spiral line and linea aspera behind, and these linea aspera behind is leading to the superior the supracondylar ridges. These are the condyles. So these are called the supracondylar ridges, the lateral one and the medial one. Of course, here is the fibula articulating with the upper part of tibia. So the vastus is arising from medialis is arising from the medial lip of linea aspera and the entire surface around the femur, like this. So this is the vastus medialis here, intermedius in between, and lateralis on this side, and all these muscles are arising from the whole surface of the femur, extending from the linea aspera, medial linea aspera, to the lateral lip of linea aspera to the medial lip of linea aspera, encircling the bone, right? And of course this muscle is aided by the rectus femoris, which is coming from the anteroinferior spine and just above the acetabulum, two heads. So these are forming the quadriceps. The vastus medialis, vastus intermedius, vastus lateralis, and rectus femoris. And this muscle is coming down, all the four heads coming down and getting inserted into the patella. So it is not inserted on the superior border but also on the lateral and medial borders of the patella, forming the lateral and the medial patellar retinaculum, and then the whole complex is inserted into the ligamentum patelli, which inserts onto the tibial tuberosity. So this is the quadriceps muscle, consisting of vastus medialis, intermedius, lateralis, rectus femoris, which is inserting onto the patella, forming onto the superior surface of the patella and onto the border of the patella, and then through the ligamentum patelli onto the tibial tuberosity. Now this, of course, is the anterior part of the knee. Now we will look at the femur from the inferior side and see that the femur consists of a medial condyle, and a lateral condyle and intercondylar notch. So this lateral condyle, you would observe that it is covered by an articular cartilage. This is covered by the articular cartilage. This part of the articular cartilage, the lower part articulates with the tibia, and this part of the articular cartilage articulates with the patella. So here you have the picture of the patella, and you would notice that the lateral condyle is more vertical as compared to the medial condyle, and it doesn't allow the patella to go laterally because the quadriceps is inserted from top, coming obliquely downwards and medially, and then goes vertically into the tibia. So this angle is called a skew angle, and because of this skew angle, there is a tendency of this to pull the patella laterally. As a bow, if the string is attached to the middle of the bow, the string will tend to move away from the curve of the bow. So this is the curve of the bow, and this will try to pull the patella laterally, and is patella laterally pushing is prevented by a more oblique lateral condyle of the femur. When this is less, then the patella is likely to dislocate laterally, and that is called as recurrent dislocation of patella. Recurrent or habitual. Habitual means all the time, recurrent means sometimes, at some frequency. Habitual means whenever you flex the knee, the patella will dislocate. Now, then from the lateral condyle would arise the anterior cruciate ligament, and from the medial condyle will be inserted the posterior cruciate ligament. And if you make the tibia on this side, tibial tuberosity anterior, this is the tibia, and here you are having the anterior tuberosity. So here you will have the intercondylar ridge. So this anterior cruciate ligament, you remember by the formula, lateral condyle gives rise to anterior cruciate ligament and medial condyle to posterior cruciate. So lateral condyle to anterior cruciate ligament and medial condyle to posterior cruciate ligament. Okay. Now on the intercondylar ridge, you remember by the formula as medial, which means the medial meniscus, anterior horn, Then you say anterior cruciate ligament, medial college. So this anterior cruciate ligament is coming and getting attached to the ridge here like this. Then you say Lucknow. So the anterior lateral meniscus is getting inserted. So then you have the medical college Lucknow, that means the lateral meniscus, and then Lucknow again, which means again the lateral meniscus, and then you have the medial meniscus. After Lucknow you have the medial meniscus, and then you have the posterior cruciate ligament coming and getting inserted behind the posterior most. So you have medial meniscus, anterior cruciate ligament, lateral meniscus again Lucknow, medial meniscus medical, and college means then the posterior cruciate ligament. So if you remember this formula, Lucknow, medical, college, and medical college Lucknow. Then you would remember from anterior to posterior, medial meniscus, anterior cruciate ligament, lateral meniscus, and of course you have Lucknow, that means lateral meniscus again, medial meniscus, college, and this means posterior cruciate ligament. So this is the sequence of attachments on the intercondylar ridge of the tibia. So this finishes all the attachments from the lateral condyle. The popliteus arises, goes behind and gets inserted onto the popliteal boundary of the posterior surface of tibia. So this is the popliteus, and of course you have the capsule supported by the lateral and the medial collateral ligament, and this part is supported by the iliotibial band and the tendon of the biceps femoris, which is getting inserted onto the head of the fibula. The lateral collateral ligament, the biceps femoris tendon, and the iliotibial band. These form the three structures on the lateral side. The three structures on the lateral side are iliotibial band, the lateral collateral ligament, and the biceps tendon. On the medial side, the capsule is strengthened by the medial collateral ligament, and this medial collateral ligament can get calcified on its superior border, and this leads to a disease which is called as Pellegrini disease. And of course there can be the injury of the medial and lateral collateral ligament, and of the menisci, and of the anterior and posterior cruciate ligament. So what can get injured? Bone can get injured, which means femur, patella, upper end of tibia, fibula. Ligaments can get injured, which means medial collateral ligament, lateral collateral ligament, anterior and posterior cruciate ligament. And then there can be a simple injury, which only synovial effusion. Alright, so these can be the various injuries, and of course there is one disease associated with the medial collateral ligament, which is called as Pellegrini disease. So this finishes off the entire femur. for you. Let us now start looking at the section of the muscles surrounding the hip. That means the head, the neck of the femur and the trochanter. And arising from the pelvis, going on to the trochanter and the upper part of the femur and even the lower part of the femur. So in front you see the flexors, the gluteus minimus, then the sartorius, then the rectus femoris, then the iliacus and the psoas major, and medial most the pectineus. See their placement. The artery, vein and nerve are placed anterior to them. And all these muscles, the gluteus minimus, the sartorius, the rectus femoris, the iliacus, the psoas major and pectineus, are passing anterior to the hip, and therefore all of them will flex the hip. Then you see laterally the gluteus medius and the tensor fasciae lata. They are passing lateral to the hip, superior and lateral to the hip, and they are inserted on the trochanter, and the tensor fasciae lata is going down with a long lever arm and it is inserted on the tip of the fibula. Both these muscles, since they are passing lateral to the rotational axis of the hip, will abduct the hip. In contrast to see the obturator externus rising from the obturator foramen, passing below the neck and inserted into the trochanteric fossa. Anterior to it is the pectineus and posterior to it is the quadratus femoris. All these three muscles have counterparts in the lower part of the adductor compartment. With pectineus, you have the adductor longus, with obturator externus, the adductor brevis, and with quadratus femoris, the adductor magnus. So all these six muscles, pectineus, obturator externus, quadratus femoris, and adductor longus, brevis, and magnus, along with gracilis, will adduct the hip. Finally, you see the muscles which are posterior. The major muscle that you see, the fattest, is the gluteus maximus. Then you have the short rotators, from above downwards, the piriformis, the superior gemellus, obturator, internus, inferior gemellus combination, which is called as the triflagellate tendon, and the lowermost, the quadratus femoris. All these muscles will externally rotate the hip and extend it. So after seeing this section and trying to memorize all the muscles that flex, abduct, adduct, extend, internally or externally rotate the hip, can be learned from this slide. Now let us look at the same slide from behind. You see the gluteus minimus, the sartorius, the rectus femoris, the iliacus, the psoas major, and the pectineus, between which is the femoral nerve, artery and vein from lateral to medial. All these will flex the hip except the artery, vein and nerve. Then you have the obturator externus between the pectineus and quadratus femoris, in the adductor compartment, and the three lower muscles of the adductor compartment corresponding to these are adductor longus, brevis, and magnus, and the medial most muscle in the adductor compartment is the gracilis. Then you see the obturator externus as it winds round the lesser sciatic notch and goes and gets inserted into the tip of the trochanter. It is flanged by the superior and inferior gemellus, and the superior to it is the piriformis and inferior to it is the quadratus femoris. And all these short rotators are covered by the gluteus maximus. So they will extend and externally rotate the hip. So this much you must be able to see again and again, visualize the placement and remember. Let us now move to the muscles in the thigh around the shaft of the femur. We have covered the muscles around the neck, now the shaft of femur, and these muscles basically arise from the femur and would control the movements of the knee, except the adductors of the hip, which will control the adduction of the hip. In the section of the thigh, notice the femur with the posterior linea aspera. From the medial lip arises the intermuscular septum, which is dividing to enclose the subsartorial canal and then the sartorius before it meets the deep fascia. So the split in the medial intermuscular septum encloses the subsartorial canal and the sartorius. From the lateral side, you see the lateral intermuscular septum which meets the deep fascia, and at the junction they form what is called as the iliotibial band, which is attached to the tensor fascia lata. Now this fascia divides the thigh into an anterior knee extensor compartment housing the vastus lateralis, intermedius and vastus medialis and the rectus femoris muscle. The split in the medial intermuscular septum houses the sartorius and its subsartorial canal, which contains the femoral vessels and nerve. The adductor compartment houses the adductor longus, brevis and magnus, supported by the gracilis. The corresponding muscles in the superior part are the pectineus, the obturator externus and the quadratus femoris. So these six combined form the adductors of the hip. Then in the extensor compartment, you see the semimembranosus and semitendinosus on the medial side and the biceps femoris on the lateral side. And between them lies the sciatic nerve. Now we have seen this quadriceps muscle, and this is the extensor of the knee. So it consists of a rectus femoris, the vastus intermedius, medialis and lateralis. Some fibers of the vastus intermedius attach to the suprapatellar pouch and they are called as the articularis genu. And all this forms the quadriceps. Now this quadriceps attaches to the superior border of the patella, to its lateral border through the medial and lateral patellar retinaculum and through the ligamentum patelli. These retinaculum are formed by the combination of the deep fascia, the vastus medialis or lateralis epinerosus, and the capsule. Then you see the ligamentum patelli, which is attached to the tibial tuberosity. You see the iliotibial band on the lateral side, and you see the head of the biceps femoris, which is attaching to the head of the fibula. Now, if you keep your finger on the anterior border and see a muscle which is medial to it, it is the gastrocnemius, and lateral to it is the tibialis anterior, along with the peronei. Then we take off these muscles and see what happens. Notice that the knee joint is formed by the lower end of the femur and its femoral and patellar articulation. The patellar articulation is larger and more vertical to prevent the patella from dislocating laterally due to the bowstring action of quadriceps, which is due to the valgus of tibia in relation to the femur. The concave part of the anterior surface of lower end of femur houses the suprapatellar pouch, which is kept pulled upwards by the articularis genu muscle, which is some fibers of the quadriceps. In the pouch, you have the medial and lateral synovial plicae, which may need resection if they impinge on the articular surface of the patella during flexion and extension. On the upper end of tibia, you notice the medial and lateral collateral ligaments. The medial one has a Pellegrini-Steedas disease, which is the calcification of its femoral attachment. And the lateral has a femorofibular and a femorotibial component. Inner to them, you notice the menisci, and attaching anterior to posterior on the intercondylar ridge of the tibia are Medical College Lucknow and Lucknow Medical College, with medial means anterior horn of the medial meniscus, see. College means the anterior cruciate ligament. Lucknow means the anterior horn of the lateral meniscus. Then again Lucknow means posterior horn of the lateral meniscus. Medical means posterior horn of the medial meniscus, and the posterior most is the college, which is the posterior cruciate ligament. From behind, you see the boundaries of the popliteal fossa. The superomedial boundary is formed by the semimembranosus, semitendinosus tendons getting inserted to the upper end and the medial surface of the tibia. Laterally, you see the biceps femoris, superolateral boundary. And the inferomedial and inferolateral are the medial and lateral heads of the gastrocnemius. And you see the sciatic nerve, the popliteal artery, and the genicular arteries emerging from them. Now you've taken off the muscles, the popliteal fossa, the gastrocnemiae. You still have the superior muscles, the biceps femoris, semimembranosus, semitendinosus. And we can see that from the lateral femoral condyle arises the popliteus, which gets inserted into the popliteal line of the tibia. Then you see the medial meniscus and the lateral meniscus. And below the popliteus, you see the tibial and the fibular origin of the tibialis posterior. Then you see the medial and lateral meniscus, and you see the posterior cruciate ligament and the anterior cruciate ligament. And you see that the posterior horn of the lateral meniscus is attached with the posterior cruciate ligament, and it is called as the meniscofemoral ligament of Risberg. What is attached posterior to the posterior cruciate ligament is called as the ligament of Risberg, and what is attached anterior to the posterior cruciate ligament is called as the ligament of Humphrey. So these are the things that you see in the knee joint from behind. Let me explain to you the movements of the knee. Supposing this is the femur and this is the tibia. So the knee may flex and the knee may extend, but when it completely extends, because of the tie rope action of the anterior cruciate ligament, the femur internally rotates on the tibia. Now, unless and until this is derotated by the popliteus muscle, it is derotated by the popliteus muscle, this axis is no longer in the correct plane to flex the knee. So when it is derotated like this by the popliteus muscle, then only can it flex again. So there is one movement which is extension, and the reversal of extension is blocked by this internal rotation of the femur. Therefore, this is called as locking. Now, even if the extensors do not contract, there is energy saving, the knee will not be able to flex. So in the knee, it flexes, it extends, and during the terminal extension, it internally rotates, and this internal rotation prevents flexion. So this is called as locking, and you must understand the locking of the knee, where the primary movement, that is extension, the reversal of the primary movement of extension is prevented by medial rotation of femur over the tibia, so that the axis of flexion extension, which is passing through the femoral condyle, is altered. So unless and until the direction of this axis is restored by derotating the femoral condyle over the tibia by the popliteus muscle, the knee will not be able to flex again. And therefore, even without extensors contracting, the extension of the knee is maintained in the weight-bearing phase of the lower limb.